Good afternoon to everyone. Welcome you all for the Cure online day 2 program. And today's sessions will be hosted by two speakers, Dr. Abbaruba Sunandani, Dr. Vaishnavi. About Dr. Abbaruba Sunandani, she completed her MBBS, MD in microbiology, and currently working with us as a consultant physician, HOD of diagnostics, and also she is managing infectious diseases. Today, she is going to present a topic on urine sample collection for culture and sensitivity. About Dr. Vaishnavi, she completed her MBBS and MD in obstetrics and gynecology and Uro Gynecology. She is also a consultant urogynecologist with us. She is going to present with topic on urinary tract infection. Good afternoon, ma'am. Good afternoon, Dr. Vaishnavi. It's a great pleasure to have you as a speaker for the day 2. Now I'm logging off and Dr. Vaishnavi will take over.
Can everybody hear me all right? Yeah? It's all fine. Okay. Yes, so I'm just going to carry on now. Can you hear me?
Yes.
Yeah, okay. So I'm just going to carry on, and today I'd just like to introduce myself. My name is Dr. Vaishnavi. I'm a urogynecologist, and an obstetrician by basic training, and urogynecology is my subspecialty. Talking about something which is... So today I'm going to be speaking about something which is like the bread and butter of urogynecology. So I'm going to be speaking about urinary tract infections. We see it a lot. About half our clinic patients are urogyne patients, and every week I have something that I learn which is new in the treatment of urinary tract. Challenging it is. Every week I have somebody who is that bit more difficult to treat. So today I'm going to share some basic information about urinary tract infections. I hope you find it all very helpful. I have some case histories at the end of it, and just to keep you occupied. And then following which, if you have any questions, I'm more than happy to take them. Yeah. So just to start it off. So urinary tract infections, like I said, very, very common, especially in the 20 to 65 age group. The incidence is about 20%. So we have had about 100 people in a hall. About 20 of the 100 people will have a UTI at some point of time. And on a regular basis, we have about 5% of women presenting to clinics with dysuria. What's called dysuria, which is burning when you pass urine. Now, of this 5% of women, about half will be urinary tract infections. Now, as the age progresses, say when it's, as the women get older, the incidence of urinary tract infection increases considerably. It's about 50% almost in the above 70s. So that's where that graph depicts what's exactly happening. So onset of sexual intercourse, let me see. So say around about the 20s, and then it slowly increases. Very, very uncommon in the age group prior to that. But in say less than 5 years, there is a small group of children who have urinary tract infections. But it is usually due to a secondary cause. It is usually due to it is due to say vesicourethral reflex in the less than 5-year-olds. So after that, it's relatively uncommon until the onset of age of sexual intercourse. When that it slowly increases, and about 40 to 50 years. The incidence of urinary tract infection keeps increasing till it reaches over 50% over the age of 70. Now, the reason for this is lack of hormones, lack of estrogen, menopause, pelvic relaxation, as the slide says, lots of hospitalization, catheterization, so on and so forth. Now, there are many types of urinary tract infections. There's complicated, there's uncomplicated, and there's recurrent. So we'll go through this as we go along. Basically, uncomplicated is an infection, an inflammation of the bladder and the urethra. It's what we call cystitis. If the upper tract is involved or it is complicated by other factors, which we'll see in the next slide, we call it complicated. So complicated UTI is when there is an obstruction, for instance, or like if it's complicated, if somebody has a stone and that is complicated by a urinary tract infection. If somebody has a structural problem, we see urethral diverticulums quite a lot. So again, if something like that complicates infection, then it's we call it a complicated UTI. Say a functional abnormality. The commonest functional abnormality I see is a raised post-void residue. It's a dysfunctional voiding. And what happens here is the patient is not emptying their bladder completely. So they have quite high post-void residues, meaning they have quite a lot of urine left behind in their bladder after they passed urine, and that predisposes them to having urinary tract infection. Secondary to systemic disorders, again, very, very common in the clinical scenario. And again, this you will see in your own nursing practice as well. When somebody comes with frequent urinary tract infections, they're usually the diabetics, they're usually the people with the renal disorders, they're usually the people on the immunosuppressants. And in actual fact, when I see somebody with frequent UTI, and if it's more than the one episode, I get them to do a complete blood work, make sure they're not diabetic or they've not got a renal disorder or something which is putting them at risk of infections. Right, so microbiology. So what causes UTI? E. coli is the commonest cause of UTIs worldwide. 70% of women will have an E. coli infection. Now, this is quite important to know because then we can start empirical antibiotics. We can start them on antibiotics that we think will work really well because we know what the organism is going to be 70% of the time. The rest is staph, saprophyticus, or other enterococcus species. Now, but if this is hospital acquired, if the UTI is hospital acquired, we find that the microbes are entirely different, and what we call the pathogen is usually either Pseudomonas or Klebsiella. So again, don't get me wrong, E. coli is still the commonest in hospital-acquired infection as well. So maybe about 50% rather than 70% in the hospital-acquired population, what we call the nosocomial infections. And the Pseudomonas and the Klebsiella is quite common too. Right, so what protects the woman from urinary tract infection? We're quite well designed. We have a whole series of protective mechanisms before we have an infection, even though it is very common. Regular voids. So if by regular voids, I mean, if you're passing urine regularly, if there's any bugs sitting there, it should just get washed out. So that is your most important protective mechanism. For instance, we have quite a large number of people who come to clinics, and I have quite a lot of them who come to clinic and say, I've had a long journey and I used a strange toilet and then I picked up an infection from there. But it's usually not a long journey and a strange toilet. It's holding back urine. It's causing a pressure in your bladder. It's putting, the various muscles that work towards emptying your bladder under stress. And that's when you pick up infection. It's less to do with the dirty toilet and more to do with the fact that you've not had regular voids or dehydrated yourself. Uromucoid, there's a mucus secretion in your urinary tract, urethra, which stops. It kind of forms like a plug and stops the pathogens entering the urinary tract or the bladder. Lactobacillus. Now, this is found usually in the vagina. And what happens is it reduces the pH or increases the acidity of the vaginal flora. And that way most of the bacteria, which is in the vagina, which should be in the vagina in the women before it gets to the urethra, will get destroyed. So if the lactobacillus is, if the vaginal flora is balanced, as we call it, then we usually don't have a problem with urinary tract infections. So this is quite important because when you give a patient antibiotics, what happens is not only do you deplete the patient of the pathogenic microbe, you also deplete the patient of the bacteria which does good for the patient. And this is one example of that. So when somebody has antibiotics, they get rid of all the lactobacillus that is in the vaginal flora. The gentle balance is lost. And because of this, the pH is not maintained. And then they end up with the vaginal infection first, which then sometimes progresses to the urinary tract infection. And this, I'm sure all of us have come across, I mean, all of you would have come across in your nursing practice too. So that the next point is about the pH of the vaginal flora and the glycosaminoglycan layer in the bladder. So this is just a little buffy coat within the bladder, which protects the bladder. And as long as you're keeping your bladder healthy, the entire bladder wall is protected by this little soft buffy coat. Right. So what causes UTI if we have all these protective mechanisms? The commonest I see, or what breaks this barrier, is sexual intercourse. And that is why the incidence of urinary tract infection increases after the age of sexual intercourse. We see this extremely commonly in clinical practice. The second commonest is instrumentation, as you can see in the pictures. There's a picture of a tertiary vaginal tape being inserted. And so when we instrument the bladder, when somebody has surgery, again, there is that delicate balance which is lost. And because of that, it increases their propensity for having urinary tract infections. Again, diabetes is very, very common cause of urinary tract infection. It's multiple reasons why that happens, and we know that diabetics are prone, their immunity is just not as good. They're prone to have any infections. So similarly, they pick up urinary tract infections as well. And they're also prone to have vaginal infections, and the pH of the vagina is just not the same as the general population. And I think all this together contributes to this UTIs in diabetics. Antibiotic use, we've just discussed it with the case scenario in the previous slide. So how do they present? We all know they present with burning during micturition, which is burning when they pass urine. They sometimes have low abdominal pain. A lot of patients present with low abdominal pain and burning micturition. Sometimes present with fever, not necessarily. We do not have to wait to the fever stage to have a UTI treated. A lot of patients, again, present with what's called urgency and frequency before it becomes dysuria even. So which is like they're going to the toilet quite a lot suddenly. So a sudden change in from going 4 to 5 times during the day to suddenly to 10 or 12 times. And then having that sense of urgency all the time, it's a sign of bladder irritation because of the infection. And loin tenderness, again, renal angle tenderness, as we call it in clinical practice, is a sign of the infection spreading to the kidneys. Very, very important to look for. So clinical exam to look for all those signs and symptoms. A general exam to look at pyrexia, back pain, numbness. A lot of people who have problems with their back, kind of lack of sensation around about their lower backs and their buttock and vagina and perineum tend to have sensory problems which can be associated with urinary tract problems. Abdominal examination again should include, palpating the lower abdomen to look for suprapubic tenderness, which is tenderness just above the pelvic bone, and loin tenderness, which is palpating the renal angles on either side, to look for signs of the kidneys being affected. Now, gynae exam is a must. This is to look for any pelvic masses. Now, a pelvic mass can be anything. It could be a pregnancy, for instance. It could be an incompletely empty bladder. It could be a fibroid putting pressure on the bladder and causing it to get irritated. So a large number of ovarian cancers we picked up as urinary tract infections. So it's usually an indication. And to look for residual urine, we usually do a quick uroflow or a scan with a post-void residue, which gives us this results, and to look for any signs of prolapse. So what investigation should be done? I know Dr. Rupa is going to speak to you about collecting specimens. Urine routine, I would say, is the most helpful investigation in clinical practice, say especially in the outpatient department. So it's usually a dipstick, or it takes about an hour or 2 to come through from the labs. And we're looking for 2 things: leukocyte esterase and nitrites, both which are produced by the bacteria, which reduces reduces these substances to produce a change in the color, and that way the dipstick gives us a different color and an indication that these two substrates are present in the urine. And once this comes up as positive, invariably there's an infection, and we can start them on treatment. Urine microscopy is a personal favorite of mine. Not only can we see the bacteria, we can see if it's gram positive, gram negative, and it gives us a rough idea of what we can treat the patient with. So I've used that in many circumstances too. Of course, urine culture is gold standard, but we have moved away from the practice of waiting for a urine culture if clinically a patient presents with signs and symptoms of a urinary tract infection. Remember, urine culture takes about 48 to 36 hours, usually more than 48 hours to come back. So remember, waiting that to 2 days is potentially going to make the patient worse, potentially going to complicate that UTI into a pyelonephritis. So we do not have that kind of time, which is why a urine microscopy is quite good, because once I know what kind of flora is in there, then we can start treatment. But if the patient is kind of asymptomatic and managing all right, and you've treated them already in the near future, it's a good idea and you're not sure of the diagnosis by the patient's presentation, it's a good idea to wait for the urine culture. Yeah. Again, we're looking for a colony count, and a colony count of more than 10.5 is significant. However, that is just for the basic knowledge, and there are times when we have treated infections with a smaller colony count, as long as the patient is symptomatic. Cystoscopy and other imaging techniques are available if the UTI is complicated and if they are resistant to infection. Treatment, of course, a mainstay is antibiotics, but more important than the antibiotics is fluid therapy. I've had mentors who've spoken to me about admitting patients in the ward just to give them IV fluids for a whole day to get rid of UTIs. And I know many of you would have worked with people who've done that in the past. We've moved away from that, but we still advise that patients drink plenty of water. So if the normal water takes about 2.5 liters on a regular day, so I advise my patients to drink maybe 4 liters. It doesn't have to be water alone, because most people find it difficult to kind of drink that much amount of water alone. It could be in the form of, say, like a yogurt drink or more, or tender coconut, or anything like that's absolutely fine. There are some blood irritants, we'll come to that, but avoiding the blood irritants, any kind of fluid intake is good. Of course, not the coffees and the teas. Now, duration. There used to be a time when 7 days was the normal treatment for urinary tract infections. We've again moved away from that. We're doing shorter courses of antibiotics for uncomplicated UTIs, meaning 3 days of treatment, and if the patient is fine, that's absolutely good. Yeah. So this way, we think the chances of non-compliance and increased resistance is, circumvented by doing a short, sharp course. Now, additional treatment regimes are sometimes used in addition to antibiotics, and these are sometimes vaginal estrogen. These are women who come with recurrent antibiotics, they come with recurrent UTIs, and sometimes we put them on low-dose antibiotics as well as vaginal estrogen. Now, there are some people who get oral estrogen tablets. Now, remember, this is associated with significant risks, and it is not warranted for just UTIs in the elderly. But vaginal estrogens, on the other hand, is very, very safe. It comes in the form of a cream, and we do short courses for about 6 weeks. There are different ways that we give the patient the estrogen, and they respond really well to it. Now, cranberry. Now, I know it's not a fruit which we are very familiar with in this part of the world, but there is some evidence, maybe some weak evidence, but definite evidence to say that cranberry is associated with reducing the amount of reinfection and reducing the amount of antibiotic use when used in people with urinary tract infection. So I give my patients who have recurrent UTIs, who have frequent problems with urinary tract infections, cranberry. I mean, the number of supplements some people take, cranberry is just a fruit. So dried cranberry or cranberry juice, as long as it's not laden with sugar, is absolutely fine. Now, sometimes we do long-term prophylaxis, which is a small dose, about 1/3 or 1/4 of the dose of the antibiotic long-term, sometimes 2 years, sometimes 5 years. And a lot of our patients are on this for recurrent UTIs. Now, recurrent UTIs, by definition, they should have had at least 2 infections in 6 months or at least 3 infections in a whole year. Then they class for treatment with long-term prophylaxis, meaning continuous antibiotic treatment for about 6 months to 2 years, depending on what their symptoms are. And then, of course, treating the cause. For instance, say they are on anticholinergics and they're not able to pass urine properly. We need to stop that and making sure we treat what is the actual cause. So we need to address that as well. Or sometimes it's just lack of understanding of the hygiene practices, and that needs to be done quite often as well. And as nurses, I think there's a huge role where we can educate the patients about how to keep hygiene, how to clean themselves after they've visited the toilet and the rest of it. And I'm sure we all do that, but it's very huge potential for patients to get better education and avoid urinary tract infections. Okay, fine. So I hope that wasn't too boring, and I hope that was enough information about, enough basic information about urinary tract infections. I'm just going to give you 3 case histories just to reiterate how diverse the topic is. So the first patient is 70-year-old. She had these are all real patients of mine, by the way. So she had multiple medical problems. She was diagnosed with what's called overactive bladder. And in fact, a neurology friend of mine who saw her for Parkinson's had referred her to me. So she had been on Tropan and Tolterodin, but the patient said she was all right with her bladder there. So when she came to me, she says, I'm all right with my bladder now, but just suddenly I'm not, I'm having a lot of pain and burning when I'm passing urine and the rest of it. She had an infection, but she was also very poor historian, as you will see with a lot of the older patients. They either the cognition is not so good, or they're affected by the medication that they're having. Or maybe they just don't remember. They don't give you a very clear history. Right, so this patient, interestingly, was on a lot of anticholinergics. What are anticholinergics? Now, a lot of the medication that we use, like I said, Tropan, Tolterodin, these are medications we use for overactive bladder. They belong to a group of drugs called anticholinergics. And what these drugs do is it just relaxes the bladder wall. So the bladder is not contracting the whole time. So by doing that, it reduces the amount of urgent continence and frequency for them. But the downside of that is because it relaxes the bladder is not contracting so well, and there is some amount of residual urine, meaning urine left behind in the bladder after they have passed urine. Yeah. So this urine that is left behind is called residual urine, and it is like a little swimming pool for all the bugs, and the bacteria just love that. And there's a collection of bacteria and urine, and causes an infection. Right. So some patients are on quite a lot of anticholinergics, and we don't know that. And this patient's already on 2 anticholinergics from the bladder doctors, or the doctors are treating their bladder. She was on more anticholinergics for her Parkinson's. She was on some anticholinergics for her sleep medication, and as a result of that, her post-void residue was 450 ml, and that pushed her into UTI. Now this patient is somebody who's had quite good care, so she got to a urogynecologist or urologist quite soon, and then we diagnosed this, stopped some of her anticholinergics, and kept her eye on post-void residue. Treated her with low-dose antibiotics. She was all right after that. But potentially, these are the patients who could go for pyelonephritis and quite ill because remember, they're quite old too, quite elderly too. So what are the other groups of anticholinergics? What other drugs have anticholinergic effect in them? Dextromethorphan, dextromethorphan as a cough syrup. Like I said, the anti-Parkinson's medication, tricyclic antidepressants like amitriptyline, some antipsychotics, all of this have anticholinergic effect. Right. So going from anticholinergics to another case history, a 25-year-old recently married, severe dysuria after intercourse. Again, probably something that we've all come across quite a lot. So the history is quite repetitive. So every time the couple have intercourse, they're newly married, and of course it's a stressful time for the couple, and every time they have intercourse, they have dysuria. So why does that happen? So spermicide use and diaphragm use is the commonest cause for this, and vaginal douching because because the couple are young and they're and it's the first time for them, and the lady probably wants to keep really clean, and they wash the vaginal area. So wash the insides of the vagina as well, which is again a very bad practice. I see this in a lot of women. Especially the women who've been abroad and come back, and they have various perfumed stuff for washing out the vagina. And I don't know why people have started doing that, but it's quite common practice. And if you see patients in your practice, doing this, definitely discourage them from doing that. Just washing on the outside is more than enough. So the treatment is very simple for this kind of dysuria or infections associated with vaginal douching, spermicide diaphragm use. It's just a single dose of antibiotic just after intercourse, and it usually settles with time. And the other thing that I advise my patients to do, which really, really helps, is voiding after intercourse and cleansing. Yeah. Right, going over to our third case history. This patient was a 45-year-old, and very interesting because it took us a long time to get to what really was bothering her. She had recurrent severe UTI, and I put her on low-dose antibiotics. She was still not responding, and when that happens, there's something definitely wrong. So I admitted her when she had with an episode of severe pyelonephritis, and I wanted to eyeball her urine specimen, and so we got a specimen in a tub to send off to the lab, and said, "Could you bring it to me?" And when we had a look at it, it looked like there were specks of something. So we were not sure what it was, to be honest. We either thought it's fecal material or some kind of worm infestation, and we sent it off to the labs, and they did confirm it was fecal material. Following which, she had an MRI and quite extensive imaging, and it actually showed, very interestingly, a colovesical fistula. Now, this patient was somebody who had a known polycystic kidney disease, and she had developed Crohn's. She was reasonably asymptomatic from the Crohn's, but had developed acquired colovesical fistula, which was just emptying into her bladder, and then she was having all these symptoms of a urinary tract infection. So she responded quite well when she had a resection of the disease segment, and had no further infections after that. So to sum up, healthy bladder. So as long as we keep a healthy bladder, we can avoid infections. And once we avoid infections, most people don't have any problems. The ones that have real problems are the ones that have that first infection, and then there's just a dip in the local protective factors, and then there's the second infection, which is maybe a little bit more severe than the first one, and the third one is a kidney infection. So when you have the first infection, it's a sign that you're not doing very well with your bladder, and in addition to getting the treatment for your infection, you also have to address what you're not doing very well, and strive to maintain a healthy bladder. So I hope you are able to take this to all your patients out there. So drinking adequately. What are healthy bladder habits? Drinking adequately, avoiding bladder irritants. Now, bladder irritants, the main bladder irritants are your teas and coffees, and your citrus juices, of course, your colas, your Coca-Cola, your Sprite, your sodas. Of course, we want citrus, it's oranges, your lemons, and all of that will irritate your bladder as well. Things that are really good for the bladder to drink is, like I said already, cranberry juice, excellent. Your yogurt drinks, excellent. Your tender coconuts is double excellent, as long as the kidneys are not affected, like super, super good. So all of that is like very good for the bladder. Yeah, anything else is fine. Any other fruit other than citrus is absolutely fine. Any fruit juices are absolutely fine too. Void frequently. Now we have this habit of I'm sure a lot of you are mothers, and we tell our children go to the toilet before we take them out and stuff like that. That's not a good idea. That's not a good habit, because voiding when you have to void when your bladder is full is a good habit. Putting pressure on your bladder when you're not ready causes some kind of malfunction of the bladder, which is not, ultimately good for the bladder. Yeah, I see a lot of young ladies who have the habit of going to the toilet before they go out and things like that, end up with overactive bladder. Avoid unnecessary medication and antibiotics, especially self-medicating on antibiotics. So you've had that first episode of UTI, you've seen your doctor, you've had your antibiotics, and you know it works. And then you've had your second episode, and then you keep taking the antibiotics. It's generally not good practice. It's definitely not good practice to take antibiotics yourself to self, especially, I suppose nurses, again, not a good idea to do yourself. Again, discourage any patients you come across from doing that. And like I said, there's plenty of things that we need to rule out before we keep taking repeated courses of antibiotics. Probiotics and cranberry is very good, and seek advice for any new bladder problems. For instance, if there's a sudden increase in the frequency or the number of times you go to the toilet, or if you have a little bit of urgency, then it's necessary that the patient is aware that they need to come and see a doctor. Yeah, and maintain good hygiene, of course. Yeah, so that I hope sums up what a healthy bladder means to all of us, patients, and I hope you can take this message across to your own homes and to all your patients as well. Yeah. Thank you very much. I'm happy to take any questions. I'm not sure if I can.
Dr. Vaishnavi ma'am, for such a wonderful presentation and informative. It was an informative session also. The participants would have gained knowledge on the urinary tract infection and how to keep the bladder healthy. Now the participants can raise their questions in chat box, and our consultant will answer your queries. Any queries from the participant side? Please drop a message in the chat box. Or shall we move ahead for the next session? Okay, thank you for participants. We'll move ahead with the second presentation. Before that, I would like to convey a message. We'll share the feedback form to your mobile number and mail ID. Kindly fill in the form at the end of each session. And each session we will be checking the evaluation and the suggestions box, and also we'll see daily presence of your participation in all the sessions. So any difficulty in receiving your ID and password, please kindly drop a message in the chat box. Thank you. And now I'll hand over the session to Dr. Abaruba Sunandini. She is going to present a topic on urine sample collection and urine sample collection for the culture and sensitivity.
Good afternoon, all of you. I am Dr. Abaruba Sunandini. I am the consultant microbiologist of Curi Hospital, Chennai. I am glad to present this topic to you, which is a collection of urine sample for culture and sensitivity. So many of you might be thinking why this topic, collection of urine sample, is such a simple procedure. Why we need to concentrate more on this collection of urine sample, you might be thinking. But then it is important because it's a very simple and very easy procedure of collecting urine, but still it has to be done very meticulously. So it is the role of a nurse or a lab technician to educate the patient about how it has to be collected. And we also need to teach them the way and all those things. Otherwise, they would collect it in an inappropriate way, and the specimen might get contaminated, and hence the reporting will get misguided, and the treatment will get misguided. So only if you know the scientific aspects behind the collection of the urine and what is being done and how the culture and sensitivity report is being given, only then you will be understanding the basic things behind the steps involved in it. So if a proper collection is done, then the diagnosis will be proper and the treatment will be appropriate. So you might be wondering what a microbiologist does with this urine, or what happens in a microbiology lab. So as you're able to see in this slide, so first you give a urine in a sterile culture container, and then we use a sterile bacteriological loop, which you're seeing here. The loop, we use that to streak the urine on the bladder plate. The plate you're seeing here is a bladder plate. You streak the urine on, we streak the urine on the bladder plate, and the next thing you're seeing is an incubator. It's a bacteriological incubator where we incubate these plates for a minimum of 18 hours at 37 degrees Celsius. And then after 18 to 24 hours, we just take the plates and see if there is any growth. If there is a growth, then we do a biochemical reaction, which you see down, and then a culture sensitivity. So you might be thinking how we give the antibiotic sensitivity, how they say it is sensitive to amikacin, sensitive to ciprofloxacin. You can see this plate. There's a green. This is a green plate. Do you recognize the organism with the color? It's Pseudomonas aeruginosa. It has a green color usually because of the pigment. So you can see the discs there, which are impregnated with the antibiotics. So CIP shows ciprofloxacin and AK shows amikacin. So first we streak the organism onto the plate, and then we keep the disc which have the antibiotics, and then we incubate it again in the same incubator and wait for 24 hours. After 24 hours, we get this kind of zone. So the zone, if there is a zone around the disc, then it shows that this organism is sensitive to this antibiotic. For example, if you can see, this is ciprofloxacin antibiotic, and there is no growth around the disc, and only farther away from the disc there is growth. So that shows that this organism is sensitive to ciprofloxacin. Similarly, for each and every antibiotic, we check the zone size around, and then we give the report. Next slide. So these are different culture and sensitivity report you might have come across in your work. As a nurse, you could have come across all these reports which says no growth, E. coli 10 power 5, insignificant growth, more than 2 types of colonies, urethral commensals grown in culture. So you might be wondering, what is this more than 3 types of colonies grown in culture? So if you see the third plate, you can see a multiple number of colonies which have grown there. So the first plate, which shows E. coli 10 power 5, you can see that the colony is very pure and uniform throughout. So that is how a significant growth will occur. So if it is like the third plate, which shows number of colonies with different morphologies, then we cannot give a proper report for this because it has not been collected properly. So even if we want to give a report, we cannot. So that time we give a report saying it has more than 3 types of colonies, and you are supposed to repeat the sample with a clean catch midstream urine. So this is the difficulty we face when they don't follow the proper protocol for collection of urine. And the second slide you see is there's no growth on the bladder plate. That means the urine does not have any organism. So you might also be seeing something like colony count, colony forming units per ml, and you might be wondering what this is and which is significant. Sometimes they say it is 10 power 5 is significant. Sometimes they say 10 power 4 is significant. Then what does it mean? So as you see in the previous slide, each colony which has come out is equal to almost 100 bacteria in there. So we calculate the number of bacteria and then we give this colony count. So this 10 power 5 CFU per ml means that there are more than 1 lakh colonies in the in 1 ml of urine. So if there are more than 1 lakh colony forming units in 1 ml of urine, then it really means that the urine is infected and there's a lot of bacteria in there. So if it is less than 10 power 3, that is less than 1000 colony forming units, then we say it is not significant. And if it is between 1000 and 10,000 colony forming units, then at times it is significant. When is it significant? When the patient is already on a prior antibiotic, when there's some obstruction in the urinary tract, when there is a fungal infection, for example, candida is present in the urine, which we have grown, so then it's significant. And then if there is a pyelonephritis in the patient, then even if the colony is less than 1 lakh, then we consider it as significant. And if you've taken the sample via suprapubic aspirate, which I'll be talking to you later, it is very significant because there's no chance of contamination if you take the urine via suprapubic aspirate. So the points you should remember when you're collecting a urine sample is it should always be collected before you start the antibiotic, mostly. Madam said if the patient is very sick, like they have burning sensation, they're not able to tolerate, fever is high, then they cannot wait for 2 more days. They might go in for pyelonephritis. In that case, the doctors decide and they start an empirical antibiotic. Otherwise, we usually recommend that the sample has to be collected before initiating or before starting an antibiotic. And then next, we usually use a wide mouth, screw capped, leak proof, sterile container. At times, nurses just take the sample in a unsterile container and send it to us, and then say, what is there? Both are similar, both are new containers. No, we cannot say that because there might be some infection already present in an unsterile container, which we use for routine urine microscopic collection. So we cannot use that sample for a culture and sensitivity. In that case, we might get organisms which are already present in the unsterile container, which might grow. And if we give that organism is present in the patient's urine, then we are misleading and we are giving a wrong treatment to the patient. So we should always use a sterile container. And then when we say screw cap, it helps us to close the container tightly, and we make sure that the urine doesn't spill out or no contaminants get into the urine. And labeling is very, very important. First thing is interchange of samples between patients, and hence the report gets interchanged. So labeling with the name of the patient is very, very important, and referring doctor, and specifically the type of specimen, whether it is a voided urine or a catheter sample or a suprapubic aspirate. All these are important because depending on how the sample was collected, the significance of the growth comes. So, and then we need an accompanied duly filled requisition form. Requisition form which should have the name, age, and the time of collection of the sample, and the antibiotic which the patient is on, and if there is any diagnosis like obstructive uropathy, vesiculated reflex, or any obstruction or anything which you want the microbiologist to know, which will put a impact on the reporting. And then it has to be transported to the lab within half an hour to the laboratory. You might think, what if I keep it 1 hour in the thing, there's no attendant to take the urine specimen. But then urine is a very nice culture medium which will help the organism to grow well. So we actually need the actual number of bacteria present in the urine. We don't need the multiplied number of organisms. So you have to transport the specimen within half an hour to the lab, or the bacteria in the urine will multiply by itself, and there might be only 100 bacteria in the sample. But if you keep it outside in the room temperature for more than half an hour, it might multiply and become 1 lakh. And when we give the report, we might give it as 1 lakh. And then the clinician will start the antibiotic, which is not of any use to the patient. Unnecessarily, we are only creating antibiotic resistance, which is very common nowadays. You know, ESBL, you know, ANSI, you know, carbapenem resistance and all has come now. So we need to be very careful about all this so that we don't start unnecessary antibiotics for the patient. If it is delayed, then we request you to keep it inside the fridge. If the logistics person does not come, if there is a delay for the attendant to take the sample to the laboratory, then we request you to keep it in the fridge at 4 degrees Celsius, minimum of 4 hours. So what are the other, if you don't have a fridge, then what else can you use? you can use a container which has 1.8% boric acid, which can preserve the urine till 24 hours. Next slide. So what are the, how can you classify these urine samples? So first, based on how you collect this, at what time you collect and how you collect. The second one is based on the method of collection, through what way you collect. So as you know, the specimen types, random sample. A patient just walks in, he has some symptom, the consultant asks you to collect the urine, you just collect a random sample. That's called a random specimen. Then comes the first morning urine, which is collected in the early morning as soon as the patient gets up. And then comes the midstream clean catch specimen, which I'll explain it to you later. And then time collection specimen, then 24 hours urine collection. Then coming to the method of collection, we have voided urine, we have transurethral and suprapubic aspiration. So random specimen, as I've already told you, this is not good for culture and sensitivity actually, but most of the patients, they come to the OP at 10 o'clock, they see the consultant at 11 o'clock and they want to finish off giving the sample. They might be coming from far and they want to just give the sample and go away and come back after 2 days for the report. In that case, we get random specimen. But even then, we can follow another procedure, which is clean catch midstream urine, which I'll explain you later. So, but always we have to take the precautions to prevent introduction of contaminants into the specimen, which I'll be talking to you later. So the first morning specimen is, as you know, as the name implies, it is the first, as soon as the patient gets up, the first sample you get in the morning, the urine which a person passes is called the first morning specimen. It is usually used for urine analysis and microscopic analysis. Since it's very concentrated throughout the night, the urine remains in the bladder and it's concentrated. It has high levels of cellular elements and proteins present. And here also we need to follow the proper collection practice, and also we have to record the timing at which it is collected. So here comes renal tuberculosis, where you need to collect 3 samples on 3 consecutive mornings, like first morning specimen. For renal tuberculosis, it is a dictum that you collect this way. So even if the bacteria, the AFB, Acidophilus bacilli, or the Mycobacterium tuberculosis is not present on the first day, it could present on the second or third day, and the concentrated specimen has more chance of showing us the bacteria rather than the dilute sample. When random specimen, it might be dilute because the patient might drink a lot of water and then immediately take the sample, which might not give you the actual picture. Whereas this first morning specimen gives you a better picture. So as I told you already, this midstream clean catch specimen, this is the best for culture and sensitivity. So some people think that when a urine stream comes, we leave the stream on the left side and stream on the right side and catch the mid part. That is not correct. Even some patients have asked us if it's that way. It's not correct. So most of you might be knowing. For the people who do not know, I just want to tell you again. So first, the patient is supposed to cleanse their urethral area with soap and water, and then dry it with a dry tissue. And then they have to let out the initial first portion of the urine into the toilet, and then catch only the midstream, and then let out the last part of the urine also. So why do we leave out the first part is, if there is any bacteria or a commensal in the urethra, so it usually comes out in the first part of the urine. When we let out the first part of the urine, it gets cleared. And then when you catch the midstream urine, it gives you the real picture of the urine in your bladder, the infected urine, or lower urinary tract infection, or upper urinary tract infection, or whatever it is. So you also need to tell the patient that they have to clean the soiled container, wipe it with a dry tissue outside, and then hand it over. So this can be done at any part of the day, could be in the morning or night, but it has to be done this way. And there are other things called time collection of specimen, where you collect it for 8 hours or 24 hours. This is not for urine culture and sensitivity, but this is another method of collection where you mark the time on the first day. Before starting the procedure, you have to completely empty the bladder and start collecting from, say, 8 o'clock today morning till 8 o'clock tomorrow morning. And then you have to mark the time and label the container and send it to the this thing. So accurate timing is very, very important. Where we use this is for 24 hours urine sodium, potassium, cortisol. We use this. So the patient's ID is very important. The name of the test required is important, and and the preservative has to be added even before the sample is collected. And then we also need to send it to the lab requisition form. You should have the date, start and end time of the sample collection and all relevant clinical details. So as I've already told you, it should be a clean catch midstream urine. You need to wash your hands with soap and water before collecting and also after the end of collecting. And when you have to, only before collecting, you have to open the urine container. And after collecting, you have to close the container very tightly. And make sure you don't touch the inner surface of the lid or the container, or the clothing or the body part does not come into contact with the inner part of the container, because all our dresses might have some bacteria or the body parts might have bacteria which might misguide the result. So we need to make sure that only the midstream urine is caught in the container. So in case of males, the prepuce has to be retracted and the glans penis has to be cleaned with soap and water, and then it has to be dried with a tissue paper. As I said, the initial urine has to be let out, the midstream has to be collected, and the rest of the urine has to be let out into the lavatory. And as we said, the lid has to be closed tightly, and the specimen has to be transported out. In case of female, they have to wash their perineum with soap and water and spread the labia wide apart and cleanse with soap and water and wipe it with a dry tissue. And then, as I said, the initial urine has to be let out, the midstream has to be caught, and the remaining has to be passed into the lavatory, and the lid has to be closed tightly, and the specimen has to be transported immediately to the laboratory. So coming to the methods of collection, collection straight from by inserting a catheter, and then from the suprapubic aspiration, and then a pediatric specimen and a cytoscopic collection of specimen. So at times, the patient may not be able to void urine. So at that point of time, we might, or a pediatric patient, we might have to use under sterile aseptic precautions with a glove, and after cleaning the glans penis or the perineum with disinfectant, we have to insert a sterile catheter which is lubricated into the urethra and then into the bladder. The urine sample has to be drained into a sterile container. And once the procedure is over, you can just remove the catheter and send the sample to the laboratory. If there is an already existing catheter, in the latest thing, we have a sampling port which you can see in the screen. So the sampling port is a place where you can collect the sample. You should never ever collect sample from the drainage bag, because it will have contaminants. It should have already there might have been urine in which one single bacteria could have multiplied to many, or there could be contamination. So you should never ever take urine sample from a drainage bag. You should only collect from this sampling port. First you have to clamp this catheter tube beneath the sampling port and leave it for 30 minutes. And then you have to just put a sterile syringe into the sampling port. And before that, you have to wipe that area with the alcohol impregnated swab or isopropyl alcohol, and then put the sterile syringe there and aspirate around 10 ml or how much ever you want. And then you have to empty it into the container and send it to the laboratory. So many catheters might not have the sampling port. In that case, what we do is we have to clamp the catheter at a little distal end, and then we have to choose the place just proximal to the clamped part. We have to choose the place where we are going to take the urine, and after some time you have to just clean that catheter's external surface with alcohol impregnated swab, and then put a needle into it and aspirate 10 ml or 5 ml urine, and then send it to the laboratory, and then remove the clamp. Don't forget to remove the clamp. So this is suprapubic aspiration of urine specimen. So suprapubic aspiration is the best because compared to they did a pediatric study for children below 2 years of age, and they found that the contamination rate was as less as 1% in suprapubic aspirate compared to 26% in clean catch midstream urine and 12% for catheterized specimen. So this is the best thing, but we cannot do it for everybody. For people whom we cannot do a clean catch midstream urine or a catheterized specimen, then you can go for a suprapubic aspiration. As I told you, in an urethral injury, they will also not be able to void. We cannot put a catheter also. So, or a urethral obstruction, or a bladder neck mass, or a benign prostatic hypertrophy, or a prostate cancer, or in case of pediatrics, in uncircumcised boys with tight phimosis or girls with labial adhesions. So here also with the under strict aseptic precautions, which means that glove, cleaning that area with betadine, and then it's usually done 1 to 2 centimeter above the pubic symphysis under local anesthesia. After cleaning that area with betadine or isopropyl alcohol, you need to put a thin needle which you use for IV injections that attached to a syringe. You have to advance, and this should be done with a full bladder, so that we don't injure any other structure. So you can wait till the bladder is full and then do this procedure. And then once you insert the needle at the 20-degree angle, the urine starts collecting when you withdraw the plunger. So after removing the necessary amount of urine, you can remove the needle, and then you can press that area so that it doesn't bleed. So pediatric specimen is the most difficult to collect. So some people say that you can collect it from the diaper. It is not right, because diaper will have other chemicals and bacteria which may be contaminants. So you cannot use diaper for collection. So what we can do is we should encourage the child to take a lot of oral fluid, and then after 30 minutes we should plan for collection of the urine specimen. We can use urine collection bags and bladder stimulation techniques. So this is the picture of the urine collection bag, which is attached to the child's perineal area. So even before that, you have to follow the strict aseptic precautions. You have to wash your hands with soap and water, and then wash the genital area of the baby and pad dry with a clean towel, and then attach this yellow part which has a sticky strip. You have to attach that around the genitals so that you can collect the urine within this bag. So you have to check the bag whether it's getting filled regularly. So once you get 10 to 15 ml of urine collected in the bag, you can remove the strip and transfer the urine to a sterile container and transport it to the laboratory. So you should not touch inside of the container or the lid. You should be very careful to do that. And then the bladder stimulation technique, which they have followed in this method, which is called Broomhall et al. So after cleaning the genital area, now one nurse is supposed to hold the child with the armpit with legs dangling, and then one nurse is supposed to gently tap the suprapubic area at a frequency of 100 taps per minute for 30 seconds. And then another nurse is supposed to massage the lumbar paravertebral area in the lower back for 30 seconds. Then we should be repeating these two maneuvers for 3 minutes. And then the same sterile bag can be attached to the child's genitals. And as we do this method, it is seen that the child passes the urine. So if the first attempt fails, then the infant can be fed with the water and formula feed. And after 30 minutes, the same maneuvers can be repeated for 3 minutes, and the sample can be collected. So cystoscopy collection is a very, very rare thing which we do not do regularly. But cystoscopy, as you know, is a diagnostic procedure in which we pass the endoscope and we use it actually to see the bladder, lower urinary tract, and prostate gland. We usually use this to find out any pathology in the bladder or lower urinary tract or prostate. But it can also be used to collect urine samples if needed at very rare circumstances. So transport of urine, as I've already told you, it has to be transported within half an hour to 1 hour, and then the processing has to be done within 2 hours. And if there is any delay in the transport or processing, it has to be stored at 4 to 8 degrees Celsius in the refrigerator to prevent bacterial overgrowth. If fridge is not available, then we can use 1.8% boric acid, which we can store it for a longer time, but to the maximum of 24 hours. So if you don't basically educate, if you think that it's a very simple procedure, if I just give the culture container and send the patient off, he will be easily able to do. So if you think like that, then I think it is high time you change your idea and give them at least this simple few points which they need to know, like clean catch midstream urine, how they have to collect, and then it has to be collected in a sterile container. The container should not be touched inside. The lid or the inner part of the container should not be touched, and it is enough if they collect 5 to 10 ml of urine, and the lid has to be closed tightly, and the labeling has to be done properly, and the sample has to be transported to the lab within half an hour to 1 hour, and the requisition has to accompany the specimen. All these things, if you keep in mind, and hereafter in your practice or in your daily OP, if you follow this, I think it would be a great help for urology practice, because urine culture and sensitivity is a very basic and very important test which is being done in urology, and which helps treating the patients at the proper time with the proper antibiotic. Thank you. If you have any doubts, I am here to answer. Yeah, so one person has shared that there's no sampling port in the catheter. That is why I told you, you can clamp the catheter at the distal end and allow the urine to get collected for 10 to 15 minutes, and then you can just clean the catheter tube just proximal to the clamp, and insert a syringe with the needle and aspirate how much, like 10 ml of urine for culture and sensitivity, and then again remove the clamp and send the sample to the laboratory. I've told you already, and someone has asked the same question, how to collect urine, how to identify whether it's a contaminated sample. That is what I told you. You cannot identify it with bare naked eyes. Only we can identify it after culturing the sample, because once we culture, only we'll know whether it has got pure growth or a contaminated growth. Only the microbiologist can say whether it is a pure sample or contaminated sample after processing. You cannot find it with your naked eyes. So cleaning with the betadine, I think you're asking that, Christy. Cleaning with betadine, one still existing. We don't clean the external genitalia with betadine, but we clean it with soap and water. That's what I was trying to say. So I think I've answered all the questions. Yeah, again the same question, how it is identified. So if we give the report as insignificant growth in culture, or more than 3 types of colonies grown in culture, or kindly repeat sample with clean catch midstream urine, then that means that the urine sample has got contaminants. So it is us who can tell. Urine culture process, as I've already told you, it has to be streaked on the plate, and it has to be incubated, and after 24 hours we see the growth and process the growth, and we do identification by biochemical reaction and sensitivity by culture and sensitivity plate, which we do on Muller-Hinton agar. Okay, so I think a lot of thank you are there. So thank you for your patient listening, and we request you to kindly fill the feedback form which will be sent to you by WhatsApp today, and only if you fill the feedback form and keep logging into the webinars regularly, we'll be able to give you the attendance and certificate at the end of 10 days. Thank you very much for your patient listening, and we'll send you the link and topics for tomorrow by 10 a.m. tomorrow. Thank you very much.